Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Amber Williams. Today's episode features Dr. Benjamin Levy from Johns Hopkins Kimmel Cancer Center in the Washington, D.C. area, and Dr. Alex Spira from Next Oncology in Virginia. They will discuss the latest developments in targeting TROP2 and TIGIT for the treatment of patients with lung cancer. This episode is part of a larger educational program titled Expert Analysis, Clinical Advances Journal Club on Emerging TROP2 and TIGIT Therapies in Lung Cancer from ESMO 2025. For more information on Dr. Levy and Dr. Spira, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
Hey everyone, I'm Alex Spira, the Virginia Cancer Specialist at Next Oncology. We're going to have a nice discussion today about TROP2 as well as TIGIT drugs. I'll let Ben Levy, my colleague and friend, introduce himself.
Hey everybody, Ben Levy. I am a lung cancer doc at Johns Hopkins, based out of Sibley, and pleasure to be here to talk about the TROP2 ADCs and maybe even touch on a little TIGIT, Alex.
Yeah, so let's begin with TROP2. TROP2 is an interesting target. It's been around for a while. We have an approved drug, sacituzumab, that has had its ups and downs. There's, I think, 3 antibody drug conjugates now that are farthest along in the space, though a lot being developed. Datopotamab, deruxtecan, sacituzumab, govitecan, and sac-TNT, as it is known. Three big ones right now. One of the big news of last year was, I think, TROPION-Lung01, which unfortunately overall was a negative study. It was close, but not quite there. And this was a randomized study in the second line of tumor-agnostic non-small cell lung cancer comparing datopotamab with docetaxel. And unfortunately, it was a negative study. And then we also had EVOKE-01, which was also negative. Do you want to talk a little bit, Ben, about what happened here and what your thoughts are?
Yeah, I think we're still wrestling with what happened. Both of these studies, TROPION-Lung01 and EVOKE-01, were trying to achieve looking at an all-comer approach in patients who were advanced non-small cell lung cancer with disease progression on chemo IO. You could have had genomic alterations, but received a targeted therapy prior. Both of these studies were straight up randomization, large studies comparing docetaxel to either datopotamab deruxtecan with TROPION-Lung01 or docetaxel versus sacituzumab govitecan with EVOKE-01. And I think, Alex, you and I would have loved to see a benefit here with these ADCs. We hate or we don't like giving docetaxel, but at least in both of these studies, there was no improvement in overall survival. Perhaps an improvement in progression-free survival, specifically in the non-squamous patient population in TROPION-Lung01, and even an overall survival in the non-squamous population and TROPION-Lung01, but that was not enough to get DXd to the finish line for TROPION-Lung01. And then EVOKE-01, similar, we didn't see statistically significant improvement in OS. These were patients that were unenriched for TROP2 overexpression, so this wasn't looking at any potential biomarker here. But in the end, unfortunately, docetaxel still remains king here in the second line. I'd love to get your thoughts on what you think happened here.
I wish I had a good answer because a lot of time, energy, patience, and money was spent here. The squamous cell population is very interesting because it was actually the flip of the curves there. Patients with squamous did worse, didn't quite bear out on EVOKE-01, but on the TROPION study, it looked like they did significantly worse. So can't really explain that. Maybe it was just patient selection, not a signal really seen in the phase 1. To me, it's a couple of things. One is these are good drugs. There's clear hints of activity there. We've had patients on the study where this drug worked. But I think at the end of the day, it's still an antibody drug conjugate. I'd fix the chemotherapy, probably some discontinuation, dose reductions, mucositis. And docetaxel, as I like to say, is the gift that keeps on giving. It always performs better. But I don't think there's a good explanation. Now, I think the hope, and I'll hope you can comment on some of this, Ben, is the biomarker strategy, right? Because, we're all about biomarkers right now. This is what everybody wants to do. IHC for biomarker never really panned out. But there's now this new biomarker that's pretty complicated that does appear to have some hints of why these drugs may work better in some patients than others. It's a nucleocytoplasma ratio. A, let me ask you a couple things, what your thoughts are. Do you think this is real? And B, do you think this is something that can be made for prime time? Because it's not that easy to actually do.
Right. So TROP2 NMR by QCS, this is a artificially intelligence assisted biomarker and first of its kind in solid tumor malignancies, and it's landed in lung cancer. I was fortunate to present this data at ASCO looking at TROP2 NMR. The long story short is that this is basically digital computational pathology where a slide is captured, it's imaged, and then through artificial intelligence is read. And the bottom line here is they're looking at TROP2 expression on the membrane of the cell as well as internally and measuring how much internal TROP2 there is versus what's on the membrane. And the bottom line is it makes sense because these drugs probably work via internalization and you want more TROP2 expression internally. And we saw this data, and maybe we can just move on to the first line of these drugs because that's where TROP2 NMR really lands. So the data with NMR really comes from the TROPION-Lung02 study. And it's a very complicated design that looked at either datopotamab deruxtecan with pembrolizumab or datopotamab deruxtecan plus pembrolizumab plus either carboplatin or cisplatin. And it was a phase 1b/2 study. And I would just say that, looking at the first line patients, treatment naive patients, both the doublet and the triplet seem to have meaningful activity. However, when you looked at TROP2 NMR expression by this digital computational pathology, it seemed like TROP2 NMR did enrich for better outcomes with Dato-DXd. So, the question is this going to be able to be recapitulated in a real world environment? Can we get this to everyday clinicians to use? My answer is probably yes, maybe not in its current iteration. But I think over time, this is the way we're heading. I mean, we are all influenced by artificial intelligence these days and AI, and I think it's going to land front and center in some of the biomarker searches. So I think for TROP2 NMR, clearly something there. I think we need more time. The second point I want to make, and then I'll just move on to the other first line data, is that TROP2 ADCs in the front line, that's a big question mark too, Alex. I mean, whether or not they land in the first line or not. I mean, the study that I presented was really two things. One, how did TROP2 ADCs perform in the front line? Two, how does TROP2 NMR perform as a biomarker? We have other study, however, with EVOKE-02. That's the other first line data with sacituzumab govitecan. Lots of different cohorts in this first line study, two cohorts looking at sacituzumab govitecan with pembro, and then a couple of cohorts looking at sacituzumab govitecan plus pembro plus carboplatin in the front line. And, the bottom line here is that there's meaningful activity in the first line. My question to you, Alex, do you think our beloved pemetrexed will be replaced by these TROP2 ADCs in the first line?
This is the real question, Ben. And I think it's a very tough answer. It's a very tough question, and it has a trial consideration and then a clinical use side as well. Let me start with the clinical trials. Pemetrexed is one of the best drugs I've ever given in terms of chemotherapy, right? And it's a few side effects. You may have to stop it after a year or so because of creatinine issues, edema, or multiple things. But patients can be on it for a long time. You might be too young to remember this, but I'm not. In the old days, we used to give 6 cycles of carboplatin and paclitaxel and called it a day. Then pemetrexed came around. And what we realized was you can actually give this drug indefinitely. And then they did a study where you can show you can give it indefinitely, and patients did mildly better. But it just shows you the tolerability of the drug. So one is, on a clinical study, you have to show not just superiority, that a drug works a little bit better, but the patients have to take that for a longer time. And you wonder, Dato-DXd or any antibody drug conjugate is going to have more side effects. What's the discontinuation rate going to be? What is the dose reduction rate going to be? What's the dose interruption rate going to be? And I think it's going to be higher. Now, whether or not that plays out over time into a meaningful survival benefit, it is unknown, because we know from other studies that maybe you don't need it indefinitely. You can probably stop after a while. But then is the real use thing, right? I mean, this is a harder drug. You're going to likely get some alopecia, which is probably underreported in the studies. You're going to have other issues. So are people going to replace, practically, if the drug gets approved and the study significant, is it going to replace our beloved pemetrexed? I'm not 100% sure. I think in some, because of survival, still survival, if it shows that. But I think there's a practicality, especially in the older population.
Yeah, I mean, I want to make 2 points. One, you're not that much older than me. I do remember the days I was around when there was 4 versus 6, a platinum doublet, or even 6 to 8. That's number one. Two is it brings into fold, I agree with you. I mean, we have to keep in mind the toxicity of these compounds. And the existential question regarding these ADCs are they targeted therapy, or are they chemotherapy 2.0? And I think we could probably agree it's probably more chemotherapy 2.0 at this point, until we find a potential real target for these drugs, for specifically for TROP2 ADCs. But I would agree, Pemetrexed is a good drug. I mean, I will be transparent and say I'm leading one of the first line studies. I'm very interested in seeing how that pans out with TROPION-Lung08, comparing Pembro versus Pembro plus Dato for PD-L1 greater than 50, asking the question, is the addition of Dato-DXd plus Pembro better than Pembro alone? Again, we'll have to see how this all shakes out, but I think we need to be cautious with the frontline data.
No, agree totally. Shifting to our next topic,
Yeah.
which is salvage of datopotamab deruxtecan, right? I mean,
Yes.
doses were drawn, but then they went back and they did two things. We knew, I mean, having participated in these studies, we saw it look like that the EGFR-mutated population did a little bit better. So they took patients from TROPION-Lung05, which is the EGFR-mutated population single-arm study. They went back and also looked at TROPION-Lung01. They put it together. And Ben, you want to talk a little bit about the data here?
Yeah, I mean, the bottom line here, more than 100 patients that were EGFR positive in this pooled analysis. And the bottom line was the response rates in a highly pretreated group of patients with north of 40% with single agent Dato-DXd. And I think that's encouraging. And we have to remember that these weren't patients in the front line or even second line. Most of these patients were multiple lines of therapy. And again, this is a pooled analysis, but it is more than 100 patients from TROPION-Lung01 and 05, roughly 117. And really meaningful activity here with a response rate that high, encouraging PFSs of around 6 months and OS, interestingly, of north of 12 months, north of a year. Again, we're still wrestling with the side effects of the stomatitis with Dato-DXd. We need to keep in mind ILD. We need to keep in mind ocular events. Those are the three AEs of special interest with this compound. But Alex, this drug is now approved by the FDA. I'd love to get your insight and your thoughts on the use of this drug, specifically in the EGFR positive patient population. Where are you using it?
So one comment before I get to that, I'll just point out, remind you that, we were all excited about patritumab, and the patritumab randomized study was negative. So this was really a salvage of an antibody drug conjugate in that same patient population. So it's nice to see. Now, getting back to your question, the EGFR world has gotten complicated. Let's leave it at that. We have Mariposa and FLAURA2 for frontline, still osimertinib, which I still think a lot of people are going to use. And, the label here is in the post-chemotherapy setting. So I think a lot of it's going to play out, but what do you get in that frontline setting? Are you getting OC? Are you getting carbopem, OC FLAURA2, or are you getting Mariposa? But I think for me right now, this clearly has a role in the post-chemotherapy setting. If you're not putting them on a clinical study, there's not much else out there. So I think it's a great option, and it really opens up options for our patients, which I think is great. I mean, this is something new, and that's where I'm using it right now. There's also there's a little hint of CNS activity, which is always a challenge with this patient population. So it's a win-win for our patients, and I think it will be used. And, that's a perfect setting though, right? Because there really is nothing. We're not worried about replacing pemetrexed. We're not worried about anything else. It's really a unique situation.
Yeah, I agree with you. I welcome this as an approval. Obviously, we'll see. They're going to have to run the phase 3 trial now, right? Versus chemotherapy post OC. And they're doing that, the confirmatory phase 3 trial. But in the interim, this drug remains approved by the FDA as of November 2025 and has been over the past few months. For me, this is a real bona fide option for patients. Again, EGFR positive patients, the world's gotten incredibly complex. I think if you're going to start a patient on FLAURA2, which is chemotherapy plus osimertinib, this does make a lot of sense if there's disease progression at that time, if you don't have a clinical trial. So I'm excited. I think the more options, the better. We, again, have to be mindful of the toxicities of these compounds. Keep in mind the stomatitis, the ocular events, the ILD, and the traditional chemotherapy side effects. But Alex, there's another compound that looks really good, sacituzumab tirumotecan, which we've got 2 studies now, one in the third line for EGFR positive patients, the OptiTROP-Lung03, and one in the second line for EGFR positive patients, the OptiTROP-Lung04. That data was presented at ASCO 2025 and ESMO 2025, respectively. Both studies showing an OS benefit, one versus docetaxel in the third line, and the other versus chemotherapy in the second line, specifically for EGFR positive patients. I'm surprised to see this. Is that data out of China? But it looks really encouraging. And the question is this drug different than the other ADCs? And where do you think this goes?
That's a tough one, right? I mean, I think we're all a little jaded about ex-US data because it's always been better there than it is here. And so I'm always a little bit concerned about that. Is SAC-TMT a better drug than sacituzumab, govitecan, or Dato-DXd? Maybe, maybe not. I've given this to a few patients and may or may not be any different than two, but the data doesn't lie, right? The data is the data. And in an early analysis in OptiTROP-Lung03, which is versus docetaxel, the overall survival rate at 12 months in, again, not completely mature, but 60 versus 45 patients, overall survival was improved 72 versus 54%, and that's a real number. If you look at OptiTROP-04, that's essentially what patritumab tried to do for their approval with sac-TMT versus carbo-pem, and progression-free survival here was markedly different, 32 versus 7%. I mean, I have to tell you, those are numbers I almost don't believe.
I would agree. I think we have to approach them with caution, but still, nevertheless, give some respect here. I mean, we remember the patritumab deruxtecan compared to chemotherapy in the second line post-dosing, no benefit at all in overall survival. But now we have the OptiTROP-Lung04, very similar design with a different ADC compared to chemotherapy in the second line post-dosing, showing an overall survival advantage. So it's hard for me to believe that these two compounds are that different, but maybe TROP2 ADCs have more meaningful activity than a HER3 directed ADC. I mean, I guess we just need larger studies, right? We need larger global studies to sort of confirm these findings.
Yeah, I mean, it's just very encouraging, right? I mean, I think we're excited. There's going to be a couple of options. Although the world's going to get very complicated if you have a couple of these approved, but I think stay tuned for sure. I think we have a couple more minutes left. Should we talk a little bit about TIGIT?
Yeah, let's do it. I mean, there's four TIGITs, right? Some have come and gone. Some are kind of here to be at least evaluated. We've got tiragolumab, who the drug came and went, unfortunately, is no longer going to be in development. We've got belrestotug also that have come and gone. These were anti-TIGIT IgG1 monoclonal antibodies. We got two other compounds that are still in the running. Domvanalimab, we've heard a lot about, and more recently, rilvegostomig, that are still in the running. With the domvanalimab data, there's a couple different studies. One is a phase 2 ARC-7 study, and the other is another phase 2 ARC-10 study. Both of these studies looking at domvanalimab plus zimberelimab, which is an anti-PD-1 drug, versus PD-1 drug alone in a high PD-L1 patient population. So essentially randomizing patients to anti-PD-1 versus anti-PD-1 plus this TIGIT, both showing improvements in PFS and maybe even small hints of OS in these very small studies. Dom is an interesting compound and is being looked at in multiple different studies. This is, again, yet another anti-TIGIT IgG1 monoclonal antibody. The second is one that I'm a little bit more excited about, rilvegostomig, which is a PD-1 TIGIT bispecific antibody. I think bispecifics are where we're heading. And the bottom line with this compound, it's been looked at in a open label phase 1 study, 2 study, and as a single agent, and has very encouraging activity. And this is a very high level overview of these compounds because I think we're still trying to figure out, we don't have more mature data. But Alex, your thoughts on domvanalimab and rilvegostomig? Did these drugs make it? Are they going to die on a vine like the other TIGITs did? Is the bispecific a better therapeutic strategy here with rilvegostomig?
There's been a lot of these out there, and there's even more that haven't even made the big four that we've talked about. And the world has been littered with failures in this for reasons that are unclear. I'm more interested in the bispecific for the reason that you say. Maybe perhaps that's idealism because it's a novel bispecific, right? It's nice to have it together, and there are some theoretical reasons, also easier to give. And there are hints of activity there too, right? So we've seen hints. The overall response rates do appear to be better, especially in the PD-L1 high. There's clearly a mechanism of action as well. Obviously at risk for more side effects when you're giving these combinations as well. Still an area of unmet need, but I think there is good hints, right? You just need to get those studies resulted. And I think the challenge is frontline studies have been really hard to recruit to in the United States. So it's a push to put people on clinical studies. But there's a whole slew of artemide studies right now looking at this, looking at that compound, as well as the ARC studies looking at it with DOM as well. And just need to get these studies done. The problem is it's been a very competitive landscape because a lot of the patients went on to the TROP2 studies. There are obviously other studies as well, and now people looking at artemide as well. So it's going to take a while for these to get done and read out, but hopefully hints of activity. I don't think the story's done yet. I do hope it's positive, but as I said, it's got a lot of negative press behind it.
Yeah. I mean, I'll finish with this, and I will date myself here, Alex. I went into lung cancer because it was easy. There were 3 drugs. There was pemetrexed, bevacizumab, and erlotinib in 2005, 2006. And gosh, the world has changed. The options that we have and the studies going on It's very complicated, but it's really an exciting time to be in the field. It's a complicated pathway for each patient, but it's a pleasure to be here and witness all these scientific advances and try to execute those in the clinic. And pleasure to work with colleagues like yourself. So it's been a pleasure to be here.
Yeah, very exciting time and very happy to, do this with you and excited for our patients, most importantly. Take care, everybody.
Thanks, everyone.
Thank you, Dr. Levy and Dr. Spira, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, expert analysis, Clinical Advances Journal Club on Emerging TROP2 and TIGIT Therapies in Lung Cancer from ESMO 2025, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.